Nice. Okay. So how I set PEEP in ARDS, I'm not going to go into the specifics of like the literature, I guess, only like where it's pertinent. Not really going to spend too much time on kind of like the nuts and bolts. Just going to assume you sort of know that, and just this is sort of like my approach to it. Because unfortunately, I think all of the guidelines, at least from ATS and the European Society, just say like high PEEP. So like, like what is high PEEP exactly? So these are the objectives, which apparently I have to have if this is a CME activity, which it's not a CME activity, unfortunately. You can let me know if you think it'd be better if it was a CME activity. I'd have to sort of like do more to get that done, but for now it isn't. But these are the objectives. Going over yet again who I am. If you can't tell by my voice, originally from Philadelphia, sort of moved to DC, a part of a mechanical ventilator course, sort of teach the vent, took my talents to Instagram, which has sort of been, plus minus experience. But I think it helps. So, or it helps some people at least. So as long as it sort of helps, I'll, try to continue to do it. All right. So what are the goals of ventilation and the goals of oxygenation? This is sort of how we teach it to our learners. So you've heard me probably talk multiple times about the goals of ventilation, goals of oxygenation. The goals of ventilation being a pH of around 7.2, which is really this permissive hypercapnia strategy, which you have to be careful with brain injury and right heart failure, but generally in ARDS and certainly in asthma or COPD, sort of accept a higher PCO2. We know that ARMA sort of pushed the PCO2 up to like 80-ish. If you have like a chronic hypercapnic patient, it might be even higher. But as long as the pH is around 7.2 without any other issues, meaning if they're hypotensive, so if they're on like 30 of norepinephrine, you can't sort of accept a pH of 7.1, it just probably is contributing to it. So you'd have to address that. We like a plateau pressure less than 30. That's more ARDS land, but we're going into the ARDS territory. We know that limiting pressures seems to be kind of like the cat's meow in mechanical ventilation. ARMA taught us that, high total volume, which is linked to high pressure, leads to worse outcomes. So we like to keep our plateaus less than 30 if we can, certainly. No or minimal auto PEEP. I guess this is more controversial than I thought because few people have reached out sort of directly either in the DMs or through comments that they don't think, auto PEEP is that bad. And, you can tolerate up to 5 or 10 or some crazy number, but auto PEEP is never good. It automatically means that you're not ventilating with the pulmonary mechanics that you have. If you have to accept auto PEEP for some reason because you can't get the rate any lower, then that's number one, a problem. And number two, has nothing to do with whether you should have auto PEEP or not. So we aim for no or minimal auto PEEP. And then I put an asterisk with driving pressure. So driving pressure, which, all we hear about is driving pressure, make the driving pressure less than 15. There's no button for that, unfortunately, because then my job would be super easy. Amato in like a big retrospective paper from the ARMA patients and the other NIH sort of ARDS patients showed that if you can keep the driving pressure less than 15, the driving pressure is your difference between your plateau pressure and your PEEP. This was tied to better mortality. So now we've moved into this driving pressure less than 15 scenario. Oxygenation, so you want to keep your SpO2 around 92%. It's a huge moving target depending on if your patient has chronic hypercapnic failure, chronic hypoxemic failure, pH, a slew of other things, but around 92%. We like to keep the FiO2 less than 60%. We know more than 60% is tied to oxygen toxicity. We like to keep it less than 60% if we can. Certainly, if you need more than 60%, your PDF ratio is probably going to be sort of in the realm of not acceptable, where you might start thinking about proning. So 60% is sort of like a nice number to shoot for. And then adequate delivery of oxygen, however you decipher that, whether it's like clinical or biochemical, or you have a swan in, or you do an echo, like whatever that is. So we'll start with a case. We'll see what ChatGPT got us. So 55-year-old male, past medical hypertension, obesity, unfortunately, 34, so probably an American, no chronic lung disease, 4 days, fever, myalgia, cough, progressive shortness of breath, sort of like bread and butter stuff. Has a fever, is tachycardic, is not really tachypnic, but 28 isn't sort of normal. Normal blood pressure, although maybe it's sort of low for his chronic hypertensive state, but that's another webinar. He's 88% on room air, which is unfortunate, and he's 94% on 4 liters. Good enough to get admitted to the hospital. We call that hypoxic respiratory failure, gets admitted to OBS or maybe the floor. He's tachypnic, diffuse crackles bilaterally. He's using some accessory muscles, but you put him on high flow and he gets a little bit better. His chest x-ray has patchy opacities. He doesn't really have a white count. His RVP is positive for rhinoenterovirus. Rhinoenterovirus really sucks. Just sort of putting that out there because, especially for kids, it just is a shitty thing to have. Initial management, high flow nasal cannula, 50, 80%, does okay with that. No antibiotics because you think it's viral. So in the next 24 hours, he deteriorates clinically, has more oxygen requirement, and he's breathing much faster, 35 to 40. He's fatiguing, decide to intubate him because of viral pneumonia and lung injury. So his follow-up chest x-ray, which wasn't as bad as this one, but now this one's like much worse, kind of like very diffuse, patchy, reticular, sort of alveolar space-filling disease. So just, the whole kit and caboodle here. So you intubate him. His post-intubation sort of initial settings are volume control, total volume of 7 ml per kg of his predicted body weight, PEEP of 8, FiO2 100% just initially, plateau pressure of 30 when you measure, and his gas on these settings is 729, 60, and PaO2 of 160. And, this is with a respiratory rate of something sort of like, where he's not going to auto PEEP, so maybe like a rate of 20 or something. If he's BMI is 34, his 7 ml per kg is probably around like 450, 500, let's say. So if you have a total volume of 750, or sorry, if you have a total volume of 450 and he's breathing 20, I mean, that's pretty good minute ventilation. It's like 9 liters per minute. So now what? So I think, what we came here for is that he has ARDS. What is the pathophysiology of ARDS? But sort of an alveolar space-filling disease that, depending on if you follow the Berlin criteria or sort of the new criteria from ATS, which, I didn't bother to memorize because I don't know how much it really matters overall, but what you essentially have is non-cardiogenic pulmonary edema that leads to surfactant depletion and dysfunction, shunt physiology, hypoxemia, and increased dead space. Because while you're delivering blood to the alveolus on the right, it can't participate in gas exchange. So it contributes to your dead space fraction. So now we're getting back to our goals. So, if these are his settings and we're getting a plateau of 30, and just by doing quick math, 30 minus 8, so he's passive on the ventilator, so you can't sort of use that against me. He's passive on the vent. He's on volume control. A question that came up earlier today was, is volume control or pressure control? There's really certainly no head-to-head studies, sort of volume control or pressure control. I personally use volume control. For people that are transport, that's going to be a little bit different depending on the ventilator you're using. You might not have a volume control option because a lot of the T1, and Melody isn't here, unfortunately. She's on vacation somewhere, which is nice. She's in like Dominican Republic, which I'm jealous. But you might not have access to like true volume control. But if I'm in the ICU, let's say, I use volume control. Why do I use volume control? ARMA use volume control, but it's not really for that reason. I think more so is that with pressure control, because the patient can take as much total volume as he or she wants, because the flow is not fixed, so they can get as much flow as they want over their inspiratory time, therefore get a volume that they sort of pull, especially if they're participating. That can go unnoticed very easily with pressure control, even if there's dysynchrony, even if there's like a cycling issue or a flow starvation issue. I personally think that if you're on volume control, you can identify abnormal much faster. The vent will ding more. We don't like the vent dinging because that means that we have to sort of like think about why is the vent dinging. But ultimately, if the vent is dinging, we should sort of go in there and figure out why is the machine keeping the patient alive dinging, right? So that's sort of like my approach. That's what I think. Everyone's a little bit different. So I'm not, not overly sure what unit you work in, who you work with. They might sort of have a different approach, but that's my approach. Anyway, so he's on volume control, 7 ml per kg, 8 of PEEP, FiO2 is 100%. Plateau's 30. So we're already sort of not there. And our gas is 729, 60, 200. So we don't have our plateau pressure goal, unfortunately. And I think it was 160, 200. He's got ARDS. Okay, so just let's not quibble over the details. So he has ARDS. His plateau pressure is not in goal, which is a problem. His driving pressure is certainly not in goal, which is also a problem. Now you could say just increase the PEEP, right? We could just increase the PEEP. That's what I hear. Make the driving pressure less than 15, just crank the PEEP up. especially if you went by the PEEP FiO2 table. If you saw on 100% with like sort of a mediocre gas, which 200, 160, 200 is like not the worst, but it's not amazing. If you went off the PEEP FiO2 table, you'd be on like 20 centimeters of water. I mean, what's going to happen if you do that? What'll happen is that your plateau pressure is definitely going to go up. Now, whether it's going to go down over time because you recruit lung, that remains to be seen. But certainly, sort of in that initial period, your plateau pressure is going to go up, and we're already at 30. So, if you go from 8 to 20, it's going to go up by some number. It's going to be over 30. So you're really not going to be in that goal. So we're hitting our pH sort of CO2 goal, right? We're 72960. I don't pay attention to PCO2. I just pay attention to pH. The pH is 729. That's well within goal. He's not on any pressors. So that's going for us. We don't have any auto PEEP, which is nice. His SAT is around 92%. His PiO2 is 200. So his SAT should be like 100. So we'll be able to sort of wean the FiO2, but that's not really going to help us overall because we're probably going to still be pretty high. And we're going to need to figure out how to sort of like get this driving pressure down because it's way too high now while also taking the plateau pressure down, hopefully. We're on 100%, so we're not reaching that goal either. And we are delivering oxygen sort of well enough. However, you figure that out, whether it's a SWAN or lactic clearance, which is the worst, or an echo, which I sort of like, or just sort of perfusion in general. So how can we impact oxygenation? Now, do any brave souls want to type into the chat how? Or you can come off mute too. I know everyone's probably peeping FiO2, my friend says. Yep, I hear that a lot. So FiO2 certainly. So FiO2, Danny says I time. Ooh, okay. So PEEP I time map. Oh, Brandon says map. Now we're starting to cook. Very nice. So I think if I got a random intern or even private intensivist like off the street and asked them that question, they would say PEEP. And remember, PEEP is part of a bigger sort of equation, which is MAP. So it's really the mean area pressure that sort of we're trying to influence when we increase the PEEP. How can we increase the PEEP, or how can we increase the mean area pressure? We can go up on the PEEP, but as Danny pointed out, we can also go up on the I time. Another way you can increase the MAP is to go up on the peak inspiratory pressure. So not that I would sort of do that, but if you were in pressure control and you were satting, 80% or something, and you made, instead of your peak inspiratory pressure being, you went from 5 to 20, so, 15 of inspiratory pressure, you can make that 30 of inspiratory pressure. That's definitely going to increase your mean area pressure. We did this before, but what mode do you really crank up the mean area pressure by going up on the airway? That's APRV. Exactly. Yeah. So Brendan's got it. APRV, right? So you really increase the mean area pressure by increasing the inspiratory pressure in APRV and increasing the I time in APRV. So it's not really, it PEEP, yes, but that's a piece of the puzzle. It's really your mean airway pressure, which is made up of your inspiratory time, your PEEP, your airway pressure, and sort of your overall IDE ratio. So, the higher pressure, longer you stay in at a higher pressure, so the inspiratory time, that's going to increase your mean area pressure. If you make your basement, which is your PEEP, higher, that's going to increase your mean area pressure. If you make your ceiling higher, which is the P airway, that's going to make your mean area pressure higher. Now, you can't make your mean area pressure like 50, right? Because that's called a recruitment maneuver, which is what we try to avoid because they kill people. And we try to avoid that at least on this channel. Maybe other channels, they don't avoid it. Okay, what does PEEP do? So PEEP does a bunch of stuff, both cardiovascularly and from a pulmonary physiology perspective. It increases your FRC, so your functional residual capacity. So after a normal tidal breath, sort of how big your lung is after you breathe a normal tidal volume out. Sort of by definition, ARDS takes you closer to residual volume, so you get below FRC. So a lot of, some of the discomfort in breathing is when you are below FRC, you have a bunch of atelectasis, you get this sort of response that you need to breathe faster and deeper to sort of, because your brain wants to sort of recruit that lung, and the best recruiter of lung is the diaphragm. Now, you might do that in inspiration, sort of able to pop those alveoli open, but as soon as you breathe out, they close down because they're filled with a bunch of junk. The surfactant's been depleted because of the ARDS. It's filled with fluid, so it collapses easier. So that's where this sort of PEEP comes in. But PEEP increases your FRC. So I think if you'd ask someone why switch someone to APRV, some proponents of APRV certainly recently would say, well, it helps you get to FRC. PEEP helps you get to FRC as well, right? It's just if you are doing APRV, you're spending a longer time at a higher pressure. So you're like doing the sort of balls to the wall recruitment maneuver. Increasing your PEEP in regular volume control, you are going to recruit lung and then get closer to FRC. So it improves your compliance because you have more lung units to participate in gas exchange. So your overall pressure is going to go down. So if you have a certain amount of volume you need to deliver, you'll need less pressure to deliver that volume because you'll have more lung units involved in gas exchange. And you improve your oxygenation through increased mean area pressure. The one slide that I probably should have sort of put in separately, but didn't get a chance to was the cardio effects of PEEP. So we know that from this sort of like U-shaped PEEP PVR curve, so your pulmonary vascular resistance is the highest at the two extremes of the lung. So if you're closer to residual volume, so if you have a bunch of atelectasis, you'll have a high PVR. Or if you're closer to TLC, so like someone who has emphysema and they have a bunch of obstruction, that's going to increase your PVR. Your right ventricle is not going to like that, and you'll have all sort of, you can certainly spiral from an RV standpoint if your PVR gets too high from either extreme. We know that PEEP helps the left ventricle because it decreases left ventricular afterload. It also helps with the transmural pressure of the left ventricle by sort of decreasing the gradient in the pericardial space. So there's sort of you increase the gradient in the pericardial space because you're adding pressure into the chest. So remember, whenever you increase a gradient, flow happens easier. It also decreases preload on the RV side. Now that could sort of either help or hurt both the RV and the LV, depending on where they are in their Starling curves sort of independently. So if you have like LV failure and you have increased PEEP, that's going to help your LV failure. However, if your LV is struggling because it needs more preload, then increasing the PEEP is going to decrease your preload, and that's going to make your sort of hemodynamics worse. So PEEP does a lot of stuff, and the authors of these guidelines really do, they certainly make it known that they're really worried about recommending higher PEEP because of the deleterious cardiovascular effects that it could have, for what that's worth. So 3 laws, not to get sort of in the weeds, but Laplace's law. So overall, it's harder. You need more pressure to open up a closed alveolus, and you need less pressure to sort of keep it open. So it's, the balloon analogy is probably the one that's the easiest to conceptualize, but remember that the lung is like sort of multiple balloons all interconnected. So while it like follows this balloon analogy, it's not like true to form because, imagine having millions of balloons that are all interconnected, right? Because, and I forgot to put this slide in too, which I could put in later, but, in the lung, the alveolus isn't sort of just like, there's not just like a bronchus that sort of branches into two, which that is true, right? We have sort of a right and left main stem. But as you get further down, you have intrabronchiolar connections. So these are called the channels of Lambert or something. I forget. You have intraalveolar connections. Those are called the pores of Kohn or Kohn, Kuhn, I think. And then you have bronchial alveolar connections, which these are the pores of Luschka, maybe. So anyway, you have multiple balloons that are all interconnected. So it is a little bit disingenuous to call the lung just one balloon. However, if you think of when you blow up a balloon, you need sort of the most pressure in the beginning to overcome that wall stress. And then as you sort of blow the balloon up more and more, it gets easier and easier, right? So the first thing that happens when you have ARDS is that you have a bunch of lung units that are collapsed down because they're full of junk, whether it's inflammatory debris or edema or something else. What you need to do is recruit those lung units, because if you don't recruit them, they're not going to participate in gas exchange, and that's going to make your shunt, your shunt, and B, your dead space fraction worse, which then gets into the second law, which is the law of diffusion, which is you need sort of multiple lung units to help diffuse gas. So if you had a bunch of lung units that weren't working because they're full of inflammatory debris and they're all atelectatic, so they're not involved in gas exchange, then by definition, you have perfusion, right? Because blood is going through, but you have no ventilation. So you have a sort of a bigger dead space fraction and a bigger VQ mismatch. Interestingly, one of the ways that you can sort of like dose PEEP is by using pulmonary shunt fraction. So if you increase the PEEP and your pulmonary shunt fraction goes down, that must mean that you've sort of recruited lung. And when you recruit lung, because you have increased lung units available for gas exchange, your shunt fraction goes down. And then you know that you've sort of like done something worthwhile. That's incredibly probably labor intensive because you need sort of multiple blood gases from multiple sites. And then you have to do the math. So it's not, I don't know if it's exactly like bedside friendly, but that's one way that you can titrate PEEP is by using the pulmonary shunt fraction. Not that I would ever do that, but if you want to torture like an intern or something, you could ask them to calculate the pulmonary shunt fraction. Lastly, compliance is based on Hooke's law. Interestingly enough, Hooke's law sort of states that each alveolus, while its own unit, also impacts the units around it. So if one of the units is sort of atelectatic, like in B on the left, then it sort of pulls those lung units towards it. Then if you deliver a tidal volume, while you might make sort of the collapse one normal size, you overdistend the ones around it. So as we provide volume, because of the viscoelasticity of the lung, the pressure goes up. And as the pressure goes up, depending on how much pressure you need to supply said volume is sort of the fundamental basis of compliance. So between these three sort of fundamental physics laws, Hooke's law, Laplace's law, and the diffusion law of a fixed diffusion law, we can like sort of understand why we would need PEEP or more positive end expiratory pressure to number one, recruit young lung units. Number two, why sort of overdistension would hurt lung units. And number three, when we do recruit lung units, how come things get better, i.e. sort of gas exchange. So a key concept in ARDS is the baby lung by Gatnoni, RIP Gatnoni. What Gatnoni said was essentially, the baby lung study and a few other studies he did, I think, with CT scans, showed that, you essentially develop like more or less a few compartments. You can at least say that the lung is heterogeneous. So there's a sort of a non-recruitable compartment, which is what I'm sort of drawing in purple. So we call that sort of or not we, because wasn't part of the study in 2005. So I was in, where was I, 2005? I guess I was like a freshman in college or something. We have a gasless compartment. We have this other compartment where sort of this ground glass is, so not completely gasless, and we call that sort of the recruitable compartment. What you're left with, again in red, is the last compartment, which is sort of normally aerated lung tissue, which is called the baby lung. It's called the baby lung because from their CT studies, what they sort of shown was the size of the lung in ARDS that is normal, quote unquote, is about this 500 to 600 grams, which is about the size of a lung in like a 5-year-old child. So the point in limiting volume and limiting pressure is that limiting volume, limiting pressure, you don't want to damage the baby lung. And you also do not want to damage the lung that you can possibly recruit. The idea with PEEP is that you want to, again, not damage the baby lung, but you also want to recruit this recruitable lung. The last slide, I'd sort of very briefly go over the recruitment to inflation ratio, which was something that like Laurent Burchard and their group and like Eddie Fan and a couple other dudes did that. So, we talk about recruitability a lot, and that's sort of like an abstract concept. With the recruitment to inflation ratio, they try to sort of demonstrate how much lung was recruitable in sort of this baby lung construct, because what they proposed was that there were sort of like two compliance curves, sort of the curve of the baby lung and then the curve of the recruitable lung. So if you can see how much lung you could recruit with more PEEP and you compare that to the rest of the lung, if you had a significant amount of lung that you recruited with higher PEEP, that you would see as you drop the PEEP and you get less volume out, then they said that this lung is recruitable. Because I think now, and you could certainly disagree or if you have different experience, but when we talk about recruitability, I don't know, me personally, I don't really know if I can point my finger and say this person is recruitable or this person is not recruitable. That's sort of like a harder thing to sort of flesh out. So what Gatnoni and they did, Gatnoni, Burchard, and the rest of our friends did was they did this ratio, which actually really easy, and they have the calculator on the website. It's actually a really easy maneuver to do. And they sort of, talked about this, and it's something that they use in their practice to figure out if the lung is recruitable or not. Now you can say like, well, what does that mean? Like, how do they use that? So if they determine that the lung is recruitable, then they would use higher PEEP to recruit said lung. If they figure out the lung is not recruitable, they're not going to sit there and go up higher and higher on the PEEP trying to recruit the lung because they know the lung isn't recruitable. So the next key concept to get into is the pressure volume curve. So I don't want this to be sort of like too nebulous, but the pressure volume curve just basically says if you are putting volume into the lung, that's going to cause there to be some pressure exerted. The change in volume or the change in pressure. So if I change my volume and I'm getting a pressure change, sort of 8th grade or I guess 9th grade, probably like 10th or 11th grade for me. But like 11th grade math is rise over run. So the slope of this line becomes your compliance. Okay. So what we're trying to do with PEEP is we're trying to avoid the lower inflection point. What is the lower inflection point? The lower inflection point, also known as sort of like the airway opening pressure, is where as you put volume into the lung, you don't get a lot of pressure change because you are recruiting lung. So as you recruit lung, as you put volume in, you don't get like a huge pressure change because as you recruit lung, you're spreading that volume out over a larger surface area. So you don't get as much pressure change. The problem is during expiration, what you're going to do is those lung units are going to collapse down again. We call that atelectasis trauma. So we set PEEP with the intention of being above this lower inflection point to avoid atelectasis trauma, which is also sort of the basis for driving pressure in a lot of ways. We avoid the upper inflection point. So the upper inflection point is just the opposite. As we put in more pressure, as we volume, we have a lot of pressure that's generated by putting the volume in. So we try to avoid that because that's where you get barotrauma from either too big a volume. So you can have, and this concept of like volutrauma and barotrauma is a little bit confusing because you can, depending on the compliance, you can give a big volume, which some would say causes volutrauma. But if you have like amazing compliance, like if you had emphysema and you gave a 10, 11, 12 cc breath, you might not have a high plateau pressure. ARMA sort of gave big volumes, right? They allowed plateau pressures up to like 40, which certainly causes barotrauma. The question is, at what level of tidal volume, if you're not having high airway pressures, is volutrauma? I think the literature would sort of say somewhere between 10 to 12. I said this multiple times before. I tend to accept higher volumes in patients with emphysema or COPD because we know they like to have bigger breaths but breathe slower. So what you're trying to do is what you're trying to sort of figure out by setting the PEEP is what is this straight line? So if you are putting in volume, you're sort of getting a step up in pressure linearly. So if you're on the straight part of this curve, that means that you're not below the lower inflection point and you're not above the upper inflection point. Therefore, you're ventilating safely. Now, if I said that the plateau pressure is 25 with some total volume that we've given, so this is FRC, and then this is FRC plus the total volume. So whatever you want the total volume to be, it could be 500 or 450, whatever it is. And I get a plateau pressure of 25. Now, I don't know what the upper inflection point is. I'd have to figure that out. But for all intent purposes, at this current compliance, when we put in this total volume, our plateau pressure is 25, which is sort of safe plateau pressure, right? It's under 30. Now, if I develop ARDS, what's going to happen to this blue line? The blue line is going to shift downward. It's going to shift downward because I need more pressure to deliver the same volume. So the red is for volume control, okay? So I need more pressure. So now I think it's going to come up, so I might as well just make it come up. That's what happens when you start playing with animation. So now I need 30. So now my plateau pressure is 35. So I start at 5 because my compliance went down. For each delta change in volume, I need more pressure to do that. So I certainly get to my upper inflection point much faster, which if we're calling 30 our sort of upper inflection point, then at some point, it maybe not be like exactly a straight line. We might sort of like, do one of these things, which is you can't really get more volume, but we're getting higher and higher pressures. Now, obviously, if you force the vent to sort of like, you can make the vent sort of pressurized to whatever you want. Remember, if you set the peak airway pressure alarm or limit to 100 and you told the ventilator you want to put in a liter, it's not going to know any better. It's just going to sort of deliver that liter, right? So you can put a liter in and it's going to pressurize to some crazy number, and then you're going to cause barotrauma and a pneumothorax. But in this situation, what we see as the blue line shifts downward and we get this new compliance curve, this new compliance line, for each delta change in volume, you have a higher delta change in pressure. And then ultimately, when you deliver the volume, you're at a higher plateau pressure, which is this 35. So we know that we want to be around 30, right? Because that's